Joining us for this MDA Engaged community webinar on telemedicine. In today's medical care landscape, telemedicine is a viable option for care for the neuromuscular community. This webinar will be an update to the telemedicine webinar held in April of 2020. My name is Michelle Barrios, and I am the Community Education Specialist at MDA. We are thrilled to have you join us today for this important and educational webinar. The webinar today is part of our larger MDA Engage flagship community event series, which focuses on bringing the neuromuscular disease community together around education and social opportunities. Be sure to visit the MDA Engage section on mda.org for updates on upcoming virtual education events. We are recording today's event and will be posting it to the mda.org website for on-demand viewing to ensure that those who are not able to join us live today are able to access this information. Please note that all phone lines have been muted. We will be having a question and answer session towards the end of the webinar. Please be sure to utilize the Q&A window to type in your questions. If you hover over the bottom of your screen, a tray of webinar icons will appear. Click on the Q&A bubble to open the window and enter your question. You do not need to wait until the Q&A session to chat in your questions. As questions come up along the webinar, please feel free to send those in. Before we begin, I would like to say thank you to our speakers, whom you will meet shortly. I would also like to thank our event supporter, Genentech. We would not be able to provide events like this if not for their generous support, so thank you very much. Let's review the objectives for today's webinar. Attendees will understand what telemedicine is, explain how telemedicine has evolved since the COVID-19 pandemic, discuss what medical visits are appropriate for a virtual visit, and learn how to have the best telemedicine visit. Now I would like to introduce our speakers. Dr. Lawson is an associate professor of neurology at Dartmouth College Geisel School of Medicine, where she has worked since 2015. She joined Dartmouth from The Ohio State University with particular interest in genetic forms of neuromuscular disease. Prior to being at The Ohio State University, she was at the University of Utah, where she completed research studies on the genetic form of neuropathies. She has been an attending physician for MDA clinics for the past 20 years, becoming director of the Dartmouth MDA Clinic in 2015. She continues to be involved in clinical research in neuromuscular disorders, both at The Ohio State University and now at Dartmouth. She continues to work with patients having genetic disorders and enjoying working with patients, residents, and fellows. Yvonne Lanouette has spent 28 years working in healthcare encompassing multiple roles, including managerial, clinical, training, education, and information systems. She now incorporates facets from all those years of experience into her current role as the embedded specialist for Dartmouth Hitchcock Neurology Department. In 1989, she ventured from her childhood home in Portland, Maine, to attend college at the University of New Hampshire, Durham, where she earned her BS in Health Management and Policy in 1993. The love of helping others has always been a part of why she chose the healthcare field, and over the years has always been the common thread through her career choices. Yvonne is excited to have found a new role where incorporating skills from her nearly completed operation and project management MS and years of work experience helping support patients, providers, and colleagues alike. And with that, I would like to turn over the webinar to Dr. Lawson and Yvonne. Let me know if you have any problems sharing, Dr. Lawson.
Okay, I'm just working on it. So just let me start by thanking you, Michelle, for that very kind introduction. And as I'm sort of setting up here, I do want to sort of reflect how this has been really an important issue, or an important sort of mission on the part of the MDA for quite some time. And Michelle, if you will just let me know if you can see that as I pull it up.
Yep, I can see it.
All right. And there.
You're ready to go?
All right, all right. So yeah, I mean, this has been an important topic that that has really been discussed for a while by the MDA in terms of, you know, sort of looking for ways, better ways to deliver health care to our muscular dystrophy patients and make sure they have the access that they need. And it's just in the recent past that this has become, you know, more of a reality for reasons that we're going to discuss. And I'm sure it's going to be an important topic going forward. So just some disclosures here. And as many of you may be aware, teleneurology is not new. This has been around in the setting of sort of acute care and especially stroke care since the early 2000s. Its application, though, in non-acute care and other branches of neurology has been fairly limited, despite its advantages, you know, including its utility in delivering care for individuals in a rural setting, for medical centers that have a large catchment area where travel distances are large, in the setting of weather or transportation challenges, as well as for people who struggle to get time off of work and family duties, both patients and caregivers. Despite these benefits of, you know, that I've mentioned, convenience, increased access, the flexibility of time and space, there have been a lot of barriers. Technology has been one of them, which Yvonne will talk about a little bit. Certainly in our neurologic community, cognitive and physical limitations. People have been sort of reluctant to engage because of loss of that personal interaction with your physician or care team, delays in getting the additional testing you may need, laboratory testing, imaging studies, especially for our MDA population, pulmonary function tests. There's issues regarding confidentiality, but probably most relevantly have been a lot of regulatory restrictions on the use of telehealth, as well as sort of billing restrictions. Well, of course, then 2020 happened. And the global pandemic really propelled a transition in telemedicine. So over 32 million cases in the United States, over 500,000 deaths. That suddenly there was a real impetus to limit infectious exposure to patients, to communities, to medical staff. This was akin to a sudden triage where doctors and providers had to decide whether to delay the care of their patients, whether to accept the risk of bringing them into clinic where they might get exposed, or to go to remote care. And obviously that really became the impetus for pushing remote care into the fore. So not only a reason to do it, but really a mandate to bring telehealth into mainstream sort of healthcare delivery. And that resulted in this, you know, this really unprecedented relaxation of some of these regulatory limitations that allowed telehealth to sort of become a reality. Of course, you know, care is not just seeing your doctors. Particularly with the MDA diagnoses, there are a number of other services, ancillary services, that are a vital aspect to care. And these are all part of this paradigm shift that's really still evolving. And organizations like the MDA are going to be playing a vital role in the future of that evolving shift and what that looks like as we move out of the pandemic era. So what about MDA diagnoses in particular? Well, there's certainly some precedent to the use of telehealth with MDA patients. A recent study came out in 2020 looking at the acceptability of using telehealth in FSH patients. This came out with sort of an acceptable rating among both patients and caregivers. But there's also been earlier pre-pandemic studies. In 2012, a Canadian group looked at using it to extend clinical genetic services in rural Canada. There's another study that came out in the later 2000s looking at being able to reduce hospitalizations with multidisciplinary telehealth services in patients with not only FSHD, but also those who were unstable, who were having some respiratory failure, as well as improved quality of life metrics in muscular dystrophy patients with telehealth programs. So there is a literature out there, not a big one, but it seems to sort of support the use of this way of delivering care. Interestingly, more recently, one of the neuromuscular bodies, the American Academy of Neuromuscular and Electrodiagnostic Medicine, or AANEM, did an online survey of patients and physicians, patients having neuromuscular disorders, physicians taking care of them, to see their responses. Almost 2/3 of physicians were doing both new and return patient visits, both by video and by phone. By far the majority of them had started that because of the pandemic, with far fewer sort of ancillary services doing telehealth. But interestingly, 3/4 of patients reported being satisfied with that modality of healthcare delivery, with only 5% being somewhat dissatisfied, and no one reporting being very dissatisfied. Not quite as rosy a picture with the physicians. A little over 50% or half of the physicians were satisfied, and a little over a third somewhat dissatisfied. But of note, again, none of the care team reported being very dissatisfied. So certainly this is a modality of care that is well accepted by patients and is evolving into being more well accepted by physicians. And I'm going to pause here and turn things over to Yvonne.
Thank you, Dr. Lawson. All right, let's see if I can get my screen sharing. All set?
Good to go?
Great, thanks, Michelle. Thank you for the opportunity to speak with everyone, and thank you for the introduction as well, Michelle. So I work on a daily basis, as we said in the beginning, in neurology. And one of those things that I do is I help train secretaries, as well as I help assist patients in getting connected with their telehealth so that they can see their provider. And in doing this, since COVID hit and we were forced to rapidly go into a telehealth mode, I have learned a lot of information and a lot of tips and tricks that essentially I'm going to share with you to get the most out of your telehealth visit. So to start, this is just about getting prepared. It is the biggest thing that I can say is preparation. So taking the time to do so will help you be successful. So telehealth visit, you may hear it called telemedicine as well. And it's just using the technology to have a medical visit. It could be with a provider like Dr. Lawson or her colleagues, but it also might be a nurse, any physical therapist, occupational therapist, speech therapist, genetic counselor, social worker, MDA rep. So we have something here called an MDA clinic that we actually every second Friday do a group approach to treating our patients that are scheduled. So providers will rotate in with as listed on this slide, seeing a patient. So the provider may see them first, and then PT will come in, and then OT, and the patient never has to leave the virtual exam room. The providers come in and out of it, and so they get to see and touch base with all of their providers that are part of their care. It allows for ease for the patient as well as good rounded care for our patients. Device choices. So sometimes, you'll hear people throw around words that you may not be familiar with. Some people are very familiar, others may not know. So they might say a smartphone or a tablet or a computer. Smartphones are your typical iPhone or an Android like a Galaxy or a Samsung. They're mini handheld computers, essentially, is what they are. Tablets might be something like an iPad, or you may have like a Surface Pro or an Amazon Fire. Both of those use something called an app, which I will talk about later, to access the software to have a good telehealth visit. And then, of course, you have your computers. Pictured here is a laptop, but you also may still have a desktop at home. And computers will have the downloaded software onto them, where you may have to set up an account depending on what software your organization that you'll be having the telehealth with uses. So advantages of telehealth, Dr. Lawson has touched on a couple of these, but one of the advantages I have found for patients is families can participate from anywhere. And this was really brought to the forefront during COVID because, of course, travel was cut to essentially nothing and people couldn't be together. And this was a way that allowed for family members such as children, brothers, sisters, what have you, to join into a telehealth visit when they couldn't be physically in the room, so they could still participate in the care of their family member. And so that was really great. The federal and state laws about where providers can actually see patients, if you will, are there, but as long as the patient is in a state where the provider is licensed and meeting all the federal and state requirements, then it doesn't matter where the family members are that are joining in. The next thing it does is it allows ease of access for scheduled visits. So one of the things that happens is, providers, just like everyone else, they have to drive in, commute to work. And so one of the things this has done and how we've handled it here is we've actually done blocks where we might have an 8 to noon block where the provider is just doing telehealth. So that allows them to sometimes start earlier and get more access in, whereas that is time they may have spent driving to and from the clinic. So in that commuter piece. So that's actually been very nice. Savings to you as a patient. So this is overall not having to the gas to get to your appointment, the potential to take time off from work, possibly finding a caregiver to watch the children if you have young children at home, or elderly or other adults that may need care. So that's a great benefit to it as well. And then patient satisfaction, as Dr. Lawson just talked about, it is the patient satisfaction numbers are actually pretty high for telehealth once you get the hang of it. So that's a little bit about that. So putting the telehealth puzzle together. So I'm just going to talk about terminology because, again, I've noticed in speaking with patients, and I have elderly parents, and speaking with them as well, that, I'll say something and they kind of get this look on their face, and I'll stop and remember that they may not know what that means. So I just want to talk a little bit about that. You may have heard the words, but you may not understand how it works and interacts and applies to this situation. So Wi-Fi, so that's your carriers, your Verizon, your Comcast, I'm not sure what's out on the West Coast, but your carrier that essentially allows you to get on the computer and get on the internet. So we live in a pretty rural area, or we're located in a pretty rural area. So one of the things that we run into is patients don't always have the strongest Wi-Fi, but they need to be strong enough to run videos when you're doing a telehealth. So practicing with a Zoom meeting with like a friend or a family, that's a free software that you could download and do a practice run and see if you can hear each other and make sure that your video is not stopping and starting, and doing that just before the visit, at some point in time, might be very helpful. So that's just a picture of where the arrow is pointing to show that it's a very strong Wi-Fi, and that's usually down in the bottom right-hand corner of your computer if you're looking at it from a computer view. A web browser is an application that is used to access various websites. So common ones are Google Chrome, Microsoft Edge, Firefox, and there are others. There are times that certain software will run better with particular web browsers, meaning like, Zoom has certain add-ons that work better with Google Chrome than it might with Firefox. So you can always go to the company website ahead of time and see if there are any recommendations. This is just a video of how those icons look for these web browsers. Pop-up blockers. This is one of the biggest things we ran into when we started with telehealth. Pop-up blockers are there built into the web browsers to stop pop-up windows from interfering with your browsing experience. So, you go to read a story, there's nothing more infuriating than going to read a news story and all of a sudden an ad pops up. That's pop-up blockers filter a lot of that out. And sometimes what will happen when you go to try and launch the software, you may see that the pop-up is blocked. And so trying to explain to patients, let's just say their appointment is at 3, and at 3:02 you're talking to them because they can't get it to work because they have this warning pop-up blocked on the screen. You can imagine trying to walk them through how to take it off, not knowing what they're on for a computer or a tablet. We don't run into them on tablets and smartphones as much, but you can imagine how difficult that will be and the time it takes. So therefore cutting into the time that the patient has with their provider. And so these are things that we want to think about beforehand, or that you want to think about beforehand. Turning off your pop-up blocker. At times you're going to need to do that because as part of the software that you'll use for virtual telehealth, you're going to need things to pop up. It's just a part of the essential navigating the site and the functionality of the actual software. This is just a quick look at, this is Google Chrome. Up in your right-hand corner of your computer, there's 3 dots, and this is how you would get into the settings. But any of this information on how to turn off your pop-up blocker on whatever browser you're using can be found ahead of time if you just search that on the internet. An app is just a shortened version of application. This is a software program that's used mainly on mobile devices, or your tablets. And this is just a picture of an app. Usually they're just little square, and they have one picture on it that identifies what it is at site. This is our MyChart application that we use through Epic, because we are on the Epic system, through Epic, so that patients can access their portal. The hyperlink is a word or a phrase image that allows for you to click away from a page to another page or a document or a section. So you have probably seen these when you've read articles and you want to find out more information about something. Wikipedia is great for that you can kind of go down these rabbit holes. But it's going to be the way that most likely you're going to access your portal or your visit. You're going to have some type of a hyperlink that is going to either be sent to you or that you may access through your patient portal. But that's what's going to bring you into your waiting room or your exam room, depending on what the organization uses. So This is a hugely important one, preparation for the provider. Dr. Lawson is going to show some pictures a little later and talk about the clinical significance of being able to have your camera in so that you can use the camera so that the provider can see everything that they need. So you can see right now I'm facing forward. You want to make sure you're safe, because the provider is going to ask you to do certain things. So you want to make sure that your chair is stationary, so that if you're asked to do arm lifts or movements, you won't roll back and slip off, because you still want to remain safe, but be able to do what the provider asks in a way that they can see it, so that you get the most of your visit. Space where you can walk or stand without any objects in your way. So you want to think about that. So get yourself set up. You can start a Zoom meeting, is how I recommend patients do this, is go on to Zoom. It's free. Get your camera set up and you can just start a Zoom meeting. And all it does is it'll allow you to share your, to turn on your video. And so then you can move your screen or your camera so you can see how you are. You can stand up in it. You can make sure there's nothing around you that if you need to stand up and walk that you're going to run into, but yet you can still see where you are on the screen. But she is going to talk and show pictures about this in a little bit. Questions to ask. This is the other thing. There's nothing worse than being told, here you go, you have a telehealth appointment. All you got to do is just get on your portal and click in. There's more to that than there's more to it than that. And if you don't know, then it's okay to ask, because you want this to be successful. We want this to be successful. So knowing the right questions to ask. Asking if you need to have a patient portal. Most bigger organizations will have a portal, and so they may have it intertwined with that, but they may not. You just need to ask, how long before my appointment should I log in? So you want to remember that just like when you're in an actual clinic, sometimes providers run behind, and sometimes you'll sit in the waiting room for 20, 30, 60 minutes. It depends what's going on and what they've had happen beforehand. So sometimes you might wait in the waiting room just as if you were waiting in the virtual waiting room, just as if you were waiting in the regular waiting room. So be patient, but it's good to ask how long before your appointment you should log in, because sometimes they run ahead of schedule. So that's really good. And then, you can get started sooner. But some of the softwares will only allow you in. So if you have an appointment at Dartmouth-Hitchcock at 3 p.m. for telehealth, you can't get in that appointment into that waiting room, let's say at 2 o'clock. It will open up so that you can join the waiting room at 2:30. We have a half an hour set. And then we have a 4-hour window after the scheduled time in case something happens and we need to move you out or what have you. So how long before my appointment should I log in? How will I access it? So this is coming back around to the patient portal. Will you get an email? Will you get a text? So for patients at Dartmouth who don't have a portal, we can, through our system, send them an email, or we can send them a text. So if they are using a tablet or a cell phone, then it makes it really easy. As long as they have the correct application, the apps downloaded on that device, they can just click that link and it will take them to where they need to go. What is the help desk number if I can't get into the waiting room or exam room? This is really important. And I will strongly say, if you're told, well, you can just go to this website, I would be pleasantly strong on getting a phone number, because talking to someone is a lot easier than getting on another website if you're already having frustrations with technology. I have found that patients do better if they can actually speak with someone, and you can be helped through that way. And then what is the software that's used by your provider? So the next slide is just going to show the different softwares that might be used, and there's all kinds of them out there. Some of them may need to have you go and download the app onto your tablet or cell phone ahead of time. Some of them may need you to download the application onto your computer that you're using, and you want to get it set up so that you can access your your microphone so you can hear yourself talking through the computer, and so that you can access your camera so that everything can transpire as expected. And then these are just a few of the popular softwares that are being used throughout the US at this point. When I did look through, electronic health records may have their own embedded software that they've designed, or they may use a different one that they've incorporated, or they might just use a different one to get, that the provider actually logs into something called Doximity, like that DoxyMe. The provider may log into Doximity in a separate account that's outside of the organization's software, but it's a secure one that meets all HIPAA guidelines. And then you would set up something called like a DoxyMe account that is a free account, and you would download that information. So the software is the application that your provider and your family will use to connect in that virtual exam room. Just a reminder that depending on the device that is used, there may be some setup ahead of time, and that's okay to ask that clarifying question as well. Thank you, and Dr. Lawson, I'm going to pass it back to you. You're muted, Dr. Lawson. Well done. Oh, there we go.
Here we go. All right, and let me get, so a good example of some of the challenges that, hang on. All right, you can see that?
Yes.
Wonderful. So yeah, good example of sort of learning how to deal with some of these challenges. There's so much that Yvonne has taught me about all these different terms, and it's definitely it's a learning curve, but it is doable. Yvonne has talked a lot about some of the technical aspects of telehealth visits, but relaxing some of these regulatory requirements also means that a lot of medical centers, a lot of offices, including our MDA clinics, are using telephone visits as well as video visits. So that does still fall under the umbrella of telemedicine or telehealth. So one of the questions is, telephone is much easier than video. What about doing a telephone visit with your physician rather than video visit? Well, most of your care team is going to really push for doing the video because there is a lot of value to having that video input, both diagnostically and otherwise. The first is just the value of a physical exam. Even a limited physical exam has value. There's a lot that especially experienced physicians will glean simply from watching people, their body language, their nonverbal cues, their movements, transitions, positions of their limbs. All those aspects are clues to how they're doing, what they're struggling with, what sort of clinical aspects or exam aspects really inform that physician to what's going on with their patient. There's also some other sort of non-patient pieces that really help your physician or care team to take care of you. Allowing your physician into your home helps him or her to understand what sort of health challenges you have, what sort of things really limit your activities of daily life. What are you coping with in your home? Is there clutter? Is there noise? Do you have the right accommodations you need? And then, of course, if you're struggling with either slurring of speech or very soft speech, or other things that make it difficult to speak and communicate with voice, a video allows you to use communication devices as well as a chat box. So what about a physical exam in a video setting? What does that look like? And I've included here some examples of some important ways that your physician can look at things that you're doing through a video. So here's an individual who is doing a lot of the maneuvers that really help them to understand. So the first one up at the top, you can see that not only can the physician or their caregiver see that you're able to lift your arms up, but also the range of motion. Can you grasp a back scratcher? And do you have the range of motion to turn and scratch your back with it? Simple tasks like grasping a cup or opening a jar can inform to what your hands are able to do, as well as some back and forth, either tapping or rapid alternating motions with your hands, which tell the physician or the provider about your dexterity, about coordination. Something we do in the clinic that is exceedingly valuable is we have people stand on their heels and on their toes. It tells us a lot about what we call distal strength. Lifting your leg up from a seated position or straightening your knee and holding it out tells us a lot about the strength closer to your body, or your proximal strength. Having both legs out gives us a lot of information about bulk, about symmetry, that is it's the same side to side. We can also look at things like the skin on your legs for any rashes, as well as any problems at the bottom of your feet, like injuries or areas of breakdown. And then finally, just doing a toe touch from a standing position tells us, can you stand? Can you balance? Do you have the range of motion to touch your toes? Are there any contractures? So a lot of information we get from some very basic maneuvers that is something that you do normally at home. The other thing I want to sort of point out here is this individual is seated at a table, but he has enough room to move his chair back so he can stand and move around a little bit to perform some of these maneuvers. He's either got a helper, or he's positioned his camera far enough so his whole body is in frame. And he's wearing a t-shirt and shorts so that the examiner on the other end can see his muscles, can look at what he's doing. So there's no clothing getting in the way of that assessment. For if you're new to the MDA, this is a first visit, or you have a new problem that you need to talk to your physician about. This is the sort of regimen they're probably going to ask you about. So first off, vital signs. Those are the things that the nurse does when you first come into a clinic, where they weigh you, they take your blood pressure, your heart rate. They may also measure your oxygen level. Some of those things you can do at home. Simply weighing yourself and being able to tell your provider what your weight is, that's useful. If you have a home blood pressure monitor, make sure you get it and record it so you can give that to your provider. A lot of wearable devices have heart rate monitors, like Apple Watches. And if you have a pulse ox, bring that with you. That's all really important information. There are obviously some aspects of the neurologic exam that are going to be difficult to check, like reflexes and sensation. But as we've just gone through, there's a lot that your provider can get in terms of a motor exam. The strength testing that we talked about with doing specific maneuvers, as well as looking at the bulk of your muscles, the range of motion, your dexterity with fine movements or rapid alternating movements, such as picking a button up off of the table or tapping on the table. Remember to wear that t-shirt and shorts so that you can really your provider can really see what your muscles and your limbs are doing. And then finally, cranial nerves. So that's all the stuff that we look at around your head, your eyes, your mouth, looking at whether you can look up for a period of time, and even taking a deep breath and counting as long as you can. That allows your provider to hear your voice, to see if you're running out of steam when you hold it. Is there any slurring? Are you having any trouble with breathing? So a lot that they can sort of pick up even for a first visit. To really optimize your visit, it's great to have a helper, an assistant. So confrontational muscle testing, that's the muscle testing that is done when you go into your clinic visit and your physician or your provider will push against you. That gives them a better, more sensitive assessment of what your muscle strength is. While it's not as good if someone else does it, you may have seen one of your physicians watching a resident or fellow do it. You can get a lot of information from watching someone else do that. So if you have a helper, a family member, a caregiver, a friend, that can help your physician with doing some of that testing. There may even be an option of doing some testing of sensation, depending on the comfort level of your assistant. Certainly that assistant person, that family member or caregiver, can be helpful with other challenges. For instance, if you have trouble standing up, or when you stand, you can do it, but you need some help with balance. So any sort of motor impairment or something that will prevent you from doing it on your own. It's something that your assistant will help you with. Sometimes it's just as simple as having someone there to take notes or to remember what was said or to ask questions. And then, of course, this is something that Yvonne sort of touched on, is the importance of sort of getting the technical aspects right. And that's something an assistant can help you with too. Adjusting your camera, so pulling it back when you're trying to push that chair out so that you can do the standing up, standing on the toes and heels. Adjusting the lighting in the room, the volume of the audio, dealing with background noise, the doorbell rings and the dog is barking, or limiting distractions like turning off the television or other things that may be going on. If you have an assistant, if you have a helper with you for your telehealth visit, make sure to think about confidentiality issues. If there's something you'd really prefer to not share with your helper, or you want to be just between yourself and your provider, think of how you're going to deal with that, whether that is a message you send prior to the visit or a follow-up phone visit, so that you can discuss some of those issues. So when should you come into clinic versus when should you sort of put yourself at risk, come into clinic rather than doing the telehealth visit? Well, there has been some guidelines out there, and recently a paper was published just this past year, looking at exactly that question in folks with neuromuscular disorders. Certainly the consensus was it is appropriate for our MDA patients who are fairly stable. But stable can be a difficult sort of term. So the corollary to that is if you are unstable, if there are significant changes going on with your health, especially things that can limit your function or compromise your life, for instance, swallowing difficulties or breathing difficulties, that's clearly something that is appropriate for an in-clinic visit rather than a telehealth visit. But there is a lot of gray zone that has to do with instability. That is something changing in your health that is changing at a greater rate than it was? Is there a new problem? Or is there something you're just not sure of? And that's when it's a good idea to consider doing, for instance, a hybrid visit. So when you're thinking about doing these visits, these are sort of the questions to consider. First off, is a clinic visit practical for me? That has to do with all of the factors that we've already talked about, weather, distance, transportation, time off, but also your comfort with exposure. If you really feel concerned about it, then telehealth is always a reasonable place, at least to start. Then is telehealth right for me? Thinking about technical issues, but I hope, after hearing from Yvonne, don't let this intimidate you. It's definitely something that is doable. You can drive a car, you can do telehealth. Telehealth is particularly useful for issues like reviewing medications. How should I take this medication? I'm having side effects. What do I do? What sort of a dose adjustment should I undertake? If you have counseling issues, questions about your health, that's a good time for a telehealth visit. If this is a well-being check or just a functional status check, that's also amenable to a telehealth visit. Or if you want to develop a strategy for care, what is my plan going forward? That's always a good venue to discuss that via telehealth. And consider hybrid approaches. That is, starting with a telehealth and then coming into clinic with the idea that you're either reducing the length or the frequency of your visit. You're developing a strategy to kind of batch everything that has to be done so you're efficient when you're in the hospital or you're in your clinic visit. You can do it the other way around, where you come into clinic and then set up a telehealth visit to review things or to go over results. Or you could do a model where you're doing every other visit by telehealth, simply to reduce the stress of coming into clinic or to reduce your exposure. That's not to say there are not problems with this, and Yvonne has touched on some of these, but I'll kind of reiterate some of the big ones that we've come across as we've really brought telehealth into our MDA care. One is the mute button. The mute button is always it's almost inevitable in these telehealth interactions. If for any reason you're having trouble with the audio portion of your video, you can always either chat to your provider that you want to perform the audio part by phone. We've done that many a times. The other thing to think about is sort of visit environment, which we've already talked about. But those distractions, how do you really optimize your camera view? And then what to do if your physician is running late, which Yvonne has also touched on. But recalling that I'm sure all of you have been in a situation where you've gone to a doctor's visit and your doctor is running 30, 45 minutes, 60 minutes late. That same thing can happen with telehealth. So just think about when you're making that visit, what is your approach to that? Do you need to give yourself extra time? Do you have a way to communicate with the office to know what's going on? So just sort of bringing some of this to a close, Telehealth was really propelled into our healthcare delivery because of a global pandemic. It's definitely here to stay. Most physicians are saying they're going to continue to engage in telehealth even after the pandemic restrictions are lifted. There's a lot of unanswered questions about this mode of delivering healthcare. Is it as good diagnostically? Do we do as good a job in diagnosing individuals who have new symptoms or new problems that we haven't seen before if we're doing it by telehealth as in clinic? Is it enough to rule out dangerous conditions? How efficient are we when we're doing telehealth? Is it really going to do are we going to do as good a job using telehealth as doing in-clinic visits long-term to affect outcomes? And how can we balance that against other risks? For instance, the risk of traveling on an icy road, the potential of losing income, or getting sanctioned at work because of lost time. All of those are likely going to be important topics that are coming. So stay tuned. I think this is an important modality, especially for the Muscular Dystrophy Association and the Muscular Dystrophy Association community. I'm sure your physicians are going to be using it more. And hopefully this is something that can really enhance your care and make things better and easier. And with that, I'll conclude and thank you for your attention.
Thank you so much, Dr. Lawson and Yvonne, for your presentation today. I'd like to now open up the webinar to any questions that anybody might have. So as I mentioned at the beginning of the webinar, if you hover over the bottom of the screen, you'll see a Q&A bubble. Click on the bubble and type in your questions, and we'll give it a second for people to type in their questions as we wait. Up here.
Michelle, while we're waiting, I wonder if I could ask a question about sort of how people have, for those who have had telehealth, if they've liked it or not.
Yeah, if any of the audience members have any comments about that, please type them in as well in the Q&A or in the chat box. I have a question that has just come in now. It says, how is the visit with a nurse practitioner different than a physician with telehealth?
Yeah, that's a great question, Cindy. That's well, at this point, it's not different. Our nurse practitioners are doing essentially the same things as our physicians, depending on their level of comfort. Some nurse practitioners who are working closely with a physician, who are sort of doing follow-up care, are more comfortable doing that sort of counseling role. But we're also sort of exploring that. So there's no reason that our nurse practitioners can't be doing exactly the same that our physicians are doing. We don't know if you know, there's any sort of difference in kind of satisfaction from the nurse practitioner versus the physicians. But I think that's going to be an important aspect going forward.
Thank you. Another question has come in. Is it the same or better to do in-person visits or a telehealth visit?
Yeah, so I think that's very dependent on a number of different factors. Your comfort level, probably your vaccination status, what sort of health challenges you have, whether you have immune compromise or respiratory problems, as well as what the goal of your visit is. So in general, if you are coming in just for a checkup, quotes, then telehealth is ideal. If you're coming in because you have questions about a medication, or you have some questions about physical therapy, or those kinds of things, that's excellent to do as a telehealth. If something is changing, then that's when it's probably best to come in for a visit. And by changing, I mean a rapid change, a new symptom, or something that just is, you don't feel is right. It's always reasonable to start out with the telehealth visit, discuss your concerns with your physician or your nurse practitioner or other provider may try to do some of these things that I mentioned. If they can't get at that answer, then they will likely want to bring you into the clinic to extend your exam. But it's always reasonable to consider sort of that high.
I'm so sorry, my doorbell rang.
That's a perfect example of telehealth challenges.
I had forewarned the both of you that a doorbell might ring today. I have a question, Yvonne, that you might have some insight on as far as insurance. Does that change for telehealth visits for the patient?
Yeah, so insurance is, during the emergency that was put into effect in almost every state and federally, the leading insurer, which is CMS Medicare, they made the decision to cover telehealth visits as if they would in the clinic, as if you were coming into the clinic. And what happens is typically when Medicare does something, or CMS makes a decision and Medicare pays, other insurances tend to fall in suit. It will be interesting moving forward to see what happens as states come off emergency, out of the emergency status that they're in, what will happen. But I would agree with Dr. Lawson. I do not think telehealth is going anywhere. There may be some restructuring, and just as with any insurance, you would have to check your individual policy, because those can even vary even before telehealth came. But a lot of them at this time that I know of are being covered the same way as if you were being seen in clinic. So.
Thank you, Yvonne, for your insight on that. I don't see any more questions coming in. It looks like you answered everyone's questions with your presentation. Just going to share my screen one more time. As I conclude the webinar, we would love to hear your comments about this webinar. If you have a smartphone, open your camera and point it at the QR code on the screen. A web page will pop up with a short survey on today's webinar. If you do not have a smartphone, once the webinar is over, a screen will pop up with the survey as well. Also, thank you again to our event sponsor, Genentech. We would not be able to provide events like this if not for their generous support, so thank you very much. If anyone has questions after this webinar, please feel free to email them to mdaengage@mdausa.org, and we will follow back up with you. If you are new to MDA through this program and are diagnosed with one of our over 43 diseases under MDA's umbrella, or are a loved one of someone who is diagnosed, we encourage you to stay engaged with MDA. You can do this by visiting mda.org/join and completing a short form. This concludes today's MDA Engage webinar, Virtual Medical Visits, a 2021 update. Thank you so much to our presenters today, Dr. Lawson and Yvonne. We appreciate your time and expertise and everything you do for the neuromuscular community, so thank you very much.